Hi, welcome everybody. My name is Kathy Service, and I'm a nurse practitioner. I'm on the board of directors of the National Task Group, and I'm also the facilitator for the NTG's online family support group for those families who have a member with an intellectual disability who is living with a dementia. Now, for those of you who are unfamiliar with the NTG, NTG stands for the National Task Group on Intellectual Disabilities and Dementia Practices. We are a 501c3 not-for-profit organization, and our mission is to advocate for services and supports for people with intellectual disabilities who are affected by Alzheimer's disease or other dementias, and also for their families and paid staff. We do this through a number of activities. First of all, through a number of our federal advocacy efforts, and also producing materials related to dementia. For instance, practice guidelines, screening tools, education and training curricula, and workshops, agency and family-based information, and other technical materials, as well as provide technical assistance. And before I introduce our moderator, I'd like to cover a few housekeeping points. First of all, everybody is muted. Secondly, please enter technology questions in the chat box. Questions related to the subject matter should be entered in the Q&A, not the chat box. Today's webinar is being recorded, as you heard, and we'll be able to share this link to you 72 hours after the session ends, and the recording will also be available at the NTG website. Language translation is available for closed captioning. If you look at the bottom of the toolbar, you can see as a participant, you can self-enable captions and switch languages by clicking on the Show Captions button and with the arrow at the bottom of your screen. So we do invite questions and comments. Please look at the Q&A box at the bottom of your screen. If you think of a question for the speaker at any point, just click into there and type your question in. And I'm holding the questions until after the speaker concludes her part of the presentation. Again, please don't put your questions in that chat box. The chat box is only used for technical questions that don't relate to the webinar content. And we aren't using the raised hand feature. I think a lot of us are used to that, but we're not going to use that to today's webinar. So please refrain from using that feature. And at the conclusion of this webinar, there'll be a brief survey that we would like you to complete that will provide us for feedback about today's webinar and probably future webinars. So I am really delighted to introduce a colleague from the NTG's Board of Directors who has also become a treasured friend to me and is today's moderator. So please welcome Marianne Barbera, who's the chair of the NTG's Family Support Committee. And she'll tell you a bit about herself and her journey here. So welcome, Marianne. Thank you all.
Thank you so much, Kathy, for that lovely introduction. Good morning or afternoon, everyone, depending upon where you are located. It is an honor and privilege to be part of today's webinar as moderator. Before I introduce today's speaker, let me tell you a little about myself and my involvement with NTG. In 2016, my beautiful beloved sister, who was an individual born with Down syndrome, started showing signs of cognitive decline. As I began my search for reputable resources and support to help guide me in learning more so I could provide the best care possible for her, I found myself unable to find the resources and support I so desperately wanted and needed. Over the course of the next several years, I did locate some helpful resources, but it wasn't until 2021 that I learned about NTG and the extremely valuable, reputable resources and monthly support group that they offer. I was so overwhelmed with gratitude for finding what I needed that I made a promise to myself in honor of my beloved sister that I would do my part to help minimize the likelihood that other families may experience the same difficulty in finding the information and support they need. As a result, I became part of NTG's Family Support Committee, was elected to become part of the board, and eventually became chair of the Family Support Committee. I am also involved with our monthly virtual support group, assisting our facilitator, Kathy Service, who you've met, and sharing my lived experience with the group members. With this involvement, myself and many other board members and committee members created an IRB-approved survey to ascertain what families felt they needed regarding aging and caring for their loved one with an intellectual disability. The results of this survey indicated a few key areas which helped us to create our very first family webinar series, which has been an ongoing collaborative effort from NTG's board members, committee members, and our Director of Operations. Today's session is the first part of that webinar series. Additionally, I'd like to mention that this webinar series is able to be offered to you free of charge due to the generous donation from a family that wishes to remain anonymous. So at this time, without further ado, I would like to introduce to you today's speaker, Dr. Mary Stevens, who will speak about the process of aging. Dr. Mary Stevens is an associate professor in family and community medicine at Jefferson. She is a family physician with 25 plus years of experience in patient care and teaching. In 2015, she co-founded the Adult Down Syndrome program at Christiana Care in Wilmington, Delaware, and continues to serve as the clinical leader. In 2018, she returned to Jefferson to help launch the Jefferson Continuing Care Program, JCCP, a new primary care practice for teens and adults with complex childhood onset conditions. She currently serves as co-director with Karen Roseman, LCSW, and the program has become the Jefferson FABS Center for Complex Care for Adolescents and Beyond. Dr. Stevens is actively involved in medical student and residency education at Jefferson and is also on the board of directors of the Down Syndrome Medical Interest Group, DSMIG, and a member of the volunteer committee for the Global Down Syndrome Foundation's Adult Healthcare Guidelines. At this time, I am going to turn the floor over to our presenter, Dr. Stevens.
Hi, everybody. Thank you so much for coming today. I was honored to be asked to speak with you all and have a conversation today. I'm a little bit overwhelmed by the number of registrants and people who made it in live today. So I just want to say thanks. Next slide. My disclosures, so this is my daughter, Callie. She is now 13, and for anybody who lives or loves somebody with Down syndrome, when I share this slide with the medical students, I always tell them Mythbuster number one, people with Down syndrome are not always this happy. She is a very sassy teen these days who will be in the ensemble for her middle school's production of Newsies. I'd also like to thank my dear friend and colleague, Dr. Adel Hergy, who helped me recruit me for this mission. And there's, I am lucky to co-direct my center with a social worker and have an OT as a close friend and colleague on campus. So it takes a team. I'm so excited to have so many folks here representing different parts of that team because everybody's vital. Next slide. So this is what we're going to do today. We're going to talk about aspects of successful aging. I expect there's, an age range of folks you all care about. And so some of the things we're going to talk about are things you can start thinking about early. And some of are things you can implement now. We're going to talk about some common co-occurring conditions in individuals with intellectual disability and how they impact successful aging. I just was talking to our medical students today, and we talked about diagnostic overshadowing. So that's when you kind of put all your eggs in one bucket and everything gets attributed to the Down syndrome or the cerebral palsy, and you're not thoughtful, you don't parse out all the many complex things that can be going on. So we're going to talk about that today. Certainly we need to think about things that are more common related to an individual's primary diagnosis, but at the end of the day, we're all human and we've got to think broadly and carefully. And then I'm going to try to share some clinical pearls. So fast facts that may make a difference and help you provide care, better care for special populations. So what's an intellectual disability? It's a disability characterized by significant limitations in both intellectual functioning and adaptive behavior. So I think this definition, when I talk with students, is really important to remember. It doesn't mean that people with ID aren't smart. It doesn't mean that they're not successful. It doesn't mean that they can't do many things. But sometimes we really have to hone our approach and think about nuanced approaches to care to present information in the way that they learn best. In somebody with cognitive decline and an intellectual disability, so that is going to change by definition over time, as while we see increasing deficits in some areas, we know that other core skills may still be preserved, and we may want to pay more attention to them. This is one of my patients at Vent Camp. So, you know, I reinforce with medical providers and trainees, but I'm speaking to the choir here. While in many ways, the patients we love with intellectual disability are vulnerable to comorbidities, they're not fragile, and we have to help them live the life that they want to live. So again, as we talk about it, intellectual disability, we need to think about intellectual functioning and adaptive behavior. And I think it's important to kind of track that over time in somebody with cognitive decline, because we may need to beef up support in one area while function is relatively preserved in another. So it's really, you're going to hear this the common theme: let's meet somebody where they are. Again, intellectual disability, you know, there are a range of disabilities or range of intellectual disability from mild to profound. But as somebody starts to lose skills related to a dementia diagnosis, we really may see gaps emerge that have to be addressed. And always pay attention to its strengths. Intellectual disability is common and probably underdiagnosed. On the positive side, up until COVID, life expectancy for those with intellectual disability was increasing. So when life expectancy increases, it may be that people also are living longer with their dementia, or more folks are getting diagnosed. Life expectancy, though, in general, is still less than the general population. And I think we're going to be figuring out all the things COVID did for many years to come. Let's think about health disparities and social determinants of health. So this is really a cascade effect. So folks who are struggling to get other resources into their daily lives may have a harder time meeting the challenges that they face. In general, we know that folks, we can go back a slide. We know that folks with intellectual and developmental disabilities are, as a whole, at increased risk for vision and hearing abnormalities. For anybody who's taken a loved one or someone you care for with ID to an eye doctor's appointment or an audiologist, we often know it may be hard to get folks through those exams and get valid information. But it's important we keep trying. We know vision and hearing are some of the skills that if we can help maintain them, folks with ID and dementia may do better. Obesity is another challenge in this patient population, which may increase the risk for cardiovascular challenges, which plays a role, also diabetes. And we think that type 2 diabetes may increase the risk of somebody developing dementia or worsen their outcome. Seizure disorder, very common in this patient population. Things to keep in mind when people have seizure disorders or diabetes or other obesity related conditions, the number of medications they're on multiplies, and this in itself can be a problem. We know skin conditions more prevalent in this patient population. Dental disease is probably the #1 public health concern of folks with intellectual and developmental disability, and certainly is going to affect speech and swallow, which may further manifest itself as somebody is experiencing decline from dementia and intellectual and developmental disability. And finally, mental health cannot be ignored or overstated. In general, we think, although we don't have great scale, so we're not sure, patients with intellectual and developmental disabilities are more likely to have depression and anxiety, which can sometimes present as dementia, but can certainly also impact skills, and people are allowed to have both. I'm gonna talk a little bit, focus a little bit on Down syndrome during this talk, because we know in general that the risk of dementia is similar in folks with intellectual and developmental disabilities, with the exception of Down syndrome, where there is a marked increase. And I see lots of families with loved ones with Down syndrome on this call. So I do want to say it doesn't mean that everybody with Down syndrome is going to develop dementia. We know there's an increased risk. Typical age of onset's in the 50s, although it can occur in the 40s. So if you take nothing else away from this talk, if you're caring for somebody with Down syndrome and a dementia diagnosis in the 20, 30, or 30s, please really question it. There is a younger age of onset, but it's too young, but not that young. So there are other just lifestyle challenges that can make the process of aging more challenging for someone with an intellectual and developmental disability. As a whole, lifestyles may be more sedentary, especially with COVID. We're seeing limitations in social networks. Yes, in some ways, Zoom can connect us with 340 colleagues on a Tuesday afternoon, 341. But that doesn't work for everybody. And then there may be more participation in passive activities. So what are key components of staying well? So access to regular medical care is important. I think it goes without saying when we talk about the risk of comorbid conditions people with intellectual and developmental disabilities have, you have to pay attention to that. But we can't forget all the other stuff all of us develop as we age. Primary care screenings are especially important. We know that cancers may be diagnosed later in somebody with an intellectual disability. And it's sometimes because we're just not trying hard enough to get those preventive screenings done. Not advocating that we should do all the preventive screenings that are recommended and make sure we're checking off those boxes. We really have to take a personalized approach to each individual. But we just, have to find that balance. And then again, can't stress enough finding the right dental home for individuals as they age. We know poor dentition can affect mood. It can affect ability to swallow and increase the risk of aspiration. And it also may create a pro-inflammatory environment, which may increase risk of things like cardiovascular disease. So what else can we do? We can encourage folks to be active. We can lead by example. There's good evidence that physical activity slows cognitive decline, improves overall physical health, reduces fall risk, which is huge. When people fall, their activity gets restricted, their world gets closed down. It can improve mental health, and it can improve sleep. And anybody caring for someone with intellectual disability, with dementia, sleep is critical for everybody in the house. We need it to maintain our creativity. The recommendation is for folks to exercise 150 to 300 minutes a week. That can be really hard to do. I'm not asking anybody to show their hands who gets their 150 minutes in. It's really hard being a caregiver. I get that. But think about, as we develop a schedule for the day or the week, how can we build in even little bursts of energy, whether it's a 10-minute walk, a bike ride, a stationary bike ride. You never grow out of Special Olympics if you want to participate. Bocce is interaction. It's using cognitive skills. You got to walk to the court. So whatever you can do to encourage your loved one or the person you care for to get out and do it. So I guess what I'm saying is, whatever stage you're at, if it's appropriate, think about these protective factors you can build into the day or the week. There was a recent study that came out that in general rated those with intellectual and developmental disability to score in the below average fitness range, and it characterized this group of folks as an extremely unfit population. Next slide. But that should not be a grim statistic that you walk away with. What this study also found was even small improvements in measure of fitness translated to a reduction in mortality risk. We know a reduction in mortality is the ultimate patient-centered outcome. So if you're doing nothing, start with something. Dancing during commercials, to the commercials, something. Just find a way to move. Don't have to get up. You can do it sitting still, but try to find something that's enjoyable for everyone. And maybe it can reduce some caregiver stress and burden as well. So of course, we want everybody to always have great expectations. And this is a 21-year-old with Down syndrome who is not extremely unfit. In fact, he's an Ironman finisher. That's not for everybody. Just start somewhere, but it's kind of cool. This is one of the pearls I took away from Adel. Find what the individual likes. If they've always hated Special Olympics, probably the time to start it is not at, or go back to it is at age 50. But what do they like? What is fun for them? How do you make it social? Does adding music help? Find out what works for the person. Eating well. Important to think about food and beverages in combination. We know that sugar sweetened beverages can add a lot of calories a day and may be a big driver for overweight and obesity. The other thing you may want to try is offering water 30 to 60 minutes before a meal if you're trying to work on portion size with the person you care for. Developing routines and habits. Some people are grazers and do better if they eat small amounts during the day. But for some folks who may need a little more structure, having routine meal times, setting up a special space for eating and drinking, can be really important to make sure we both get in good nutrition and to avoid, too much snacking or excess caloric intake. Again, as somebody has a decline in function, you may have to work a little harder to find out what still works for them, and what consistency is best. I will always talk about an interdisciplinary team, so don't think you have to do this on your own. Occupational therapists can be a huge help, speech therapists. In some places, you're lucky enough to have good dietitian support. Think about what you need to get done. In general, we talk about reduced sodium intake being positive for healthier outcomes. We do know that our patients with Down syndrome tend to run really low blood pressures. So the caveat here is if you love somebody with Down syndrome, you may be able to take out the salt shaker a little bit more. So you as a supporting person, what do you need to think about? Lots of things. So really, you need to think about the big picture. Where does the individual you support live? Whether they're your family member or not. Who do they live with and for how long? I know in the practice in both Philadelphia and at Christiana Care, we will sometimes find siblings jumping in to care for a loved one. So sometimes the person who may be the paid caregiver in the relationship actually has the most knowledge of the patient and their likes and dislikes. I think really important from a medical provider standpoint, but also in terms of understanding the decision maker is who, the bigger picture is who is that individual's decision maker. Is there a guardianship in place? And I'm not advocating for guardianship at all, but you need to know what's out there. Is there a power of attorney in place? Is the person practice supported decision making? If they have cognitive decline, is that still going to be a workable solution, or do we need to think about putting something else in place? Make sure there's anybody responsible for caring for the individual is aware of their associated medical conditions. Common medical conditions that we treat in someone with intellectual disability, like say urinary incontinence or an inability to control the flow of urine. Some of those medicines can cause side effects. So in addition to knowing the medical conditions, make sure there's a clear picture of what medications the individual is on and are they still the right medication for the person at that time. And then understanding baseline, we're all unique. And if, for example, somebody with Down syndrome, somebody with Down syndrome. So if they're typically a very quiet, reserved person, that's who they are. But if they're typically really outgoing and the life of the party, and suddenly they're not, well, then that's a problem. So we never want to assume. So just to kind of sum up, what are the keys to successful aging? So avoiding disease, and this often has to start decades earlier. Maintaining high cognitive and physical functioning. That's something we can try to do every day. And then maintaining engagement in life. oh so important. And in someone with dementia who is perhaps losing some skills, it's important to then reevaluate and meet that person where they are. So I talk about, hey, maybe it's time for them to retire from their job of 20 or 25 years. Maybe that schedule, the best thing for them to do is not to be more active, but to pull back and allow time for adequate rest at night. Let them sleep in. Maybe they need that little nap in the afternoon to keep going. This is a chapter, there's a chapter in this book, Care of the Elderly, that I co-wrote with Dr. Hergy and Dr. Rochelle Renee, who is a psychologist. So it's on care of the elderly overall, but there's an updated chapter on caring for those with intellectual and developmental disability. And it may be helpful as background for your team. Other chapters may be useful as well. Although some of our folks with IDD who have dementia are not in the age range that you would typically think of as being elderly. We know this is a group that experiences premature aging. And so many geriatric principles can actually be really helpful as we meet the person where they are. Again, we've kind of gone through this. So we have to never lose track of those comorbid conditions and in our folks with IDD. When I'm evaluating somebody, I really make myself pause and take a head to toe approach. So maybe this behavioral outburst is not really a sign that their dementia is progressing, but maybe it's they have really bad folliculitis or, little hair bumps, or maybe it's because they have a huge ball of wax in their ear, so they're not hearing what you say. So again, thoughtful, top to toe, think about the person first, and then think about what might be related to aging or dementia. Again, I mentioned social determinants of health in the introduction, and this can really have a cascade effect on an individual. So, we start with an individual's comorbidities and their underlying condition or syndrome, and then key social determinants. Can they access care? Can they access quality care? If you as the caregiver don't think you're getting what you need, don't be afraid to ask for it. When we had Callie, and she was great until 6 months old. The diagnosis of Down syndrome was a bit of a surprise, but we're like, she's our girl, our long-awaited Callie girl. But when she developed difficulty breathing, it got written off as, well, she has Down syndrome. And I was like, gee, in medical school, you never learn about difficulty breathing caused by Down syndrome. So let's think. It's no fun to fire a care provider, but sometimes it's what needs to happen. So make sure you're getting that quality care. There can be some true challenges with screening and detection of disease. Again, some of our folks with ID or maybe co-occurring diagnosis of autism have sensory issues. They may not have the language skills or the patience for routine eye screening or detecting hearing loss, or maybe they can't tolerate wearing hearing aids. But through your local networks, you may be able to find providers who they can do well with, and other adaptations in the home or living environment that can improve those conditions. Communication barriers, again, something we have to think about. We do know there is a lack of validated scales to diagnose depression and anxiety in this patient population, so you have to be suspicious perhaps and provide that information to the care team. Just to go through some clinical pearls for Down syndrome, some of these we've covered, but we're going to just hit a few before we wrap up and open for questions. We've talked about this, but I'm going to say it again. It's not inevitable that somebody with Down syndrome is going to develop Alzheimer's disease. And it's rare before the age of 40. So if you love somebody or care for somebody with DS, don't let them get that diagnosis too soon. Be on the lookout for other causes. This is a recommendation out of the Global Down Syndrome Guidelines. Again, that emphasizes that point about dementia being rare in adults with Down syndrome less than 40. It does make the recommendation that professionals should assess adults with Down syndrome through caregiver interview, but I also think through input of the patient, if at all possible, annually beginning at age 40. And a decline in these 6 domains on the NTG EDSD. So thank you, NTG. That's the NTG early dementia. Oh boy, I'm going to get these initials wrong. But anyway, it's a screen for people with Down syndrome and dementia that is on the NTG website. And it can be helpful both to identify early stage age-related Alzheimer type dementia and or potentially reversible causes. So I use this in my program all the time. In folks with Down syndrome, I've heard people say, well, it's really long. What we try to do is give it out in advance of the visit, and then we all review it together at the time of the visit. If folks are mailing it back to me after the visit, I tell them to keep a copy of it. Because it's a time investment to complete it, but I think is really helpful and may make us think more as care providers of what else could we be doing to help that individual live their best life. And it may not be diagnosing them with dementia, or it may be. Other pearls, low-hanging fruit for caring with people with Down syndrome, that thyroid needs to get checked annually or more frequently if symptoms develop. We talk a lot about instability of the neck and hips and joints of somebody with Down syndrome as kids. Well, all that flexibility leads to early arthritis. So maybe the reason they're not walking or they're afraid of steps is not because they have dementia, but because they have horrible arthritis. Hearing impairment, really common. So is earwax in people with Down syndrome. And certainly there may be a role for testing, treatment, speech therapy, other devices. And then we may want to screen for low bone density earlier in life than standard guidelines because we know somebody with a hip fracture is going to lose a lot of skills during that recovery period and may lose some of their mobility. Overweight and obesity, it's something, you know, we need to think about it. We typically see weight loss in people with Down syndrome and dementia. So pay attention to that, but you know, think early in terms of helping people maintain the healthiest body weight than they can. Don't forget about congenital heart disease and lose that history as folks transfer from one care provider to another, but know that the actual risk of a heart attack from coronary artery disease is quite low. Menopause may be earlier. Unfortunately, hormone therapy doesn't seem to improve outcomes except for symptoms. And then sleep apnea, 70 to 90% of adults with Down syndrome have sleep apnea. We know that untreated sleep apnea leads to a decline in cognitive function. So we really need to treat it if we can. There's some surgical approaches now for that person who just can't get used to their CPAP or BiPAP. I've seen occupational therapists do amazing things to help people acclimate. I've actually seen patients who move to group homes and it's their direct support professional who really gets them into their CPAP because that's the routine. Like most things in life, it's okay to just do something and not be perfect. We see clinical benefits from people who use their CPAP at least for 5 hours, 5 days a week. So don't quit unless it's really time to quit. But give it your best shot. So in Down syndrome, type 2 diabetes may be more common, but typically we don't see some of the bad outcomes in terms of vascular problems like heart attack and stroke in people with Down syndrome, but we do have to be really careful about the risk of low blood sugars, which can cause brain injury and be problematic. So as somebody's progressing through different stages of cognitive decline or dementia, we may be more apt to tolerate a higher hemoglobin A1C, which is the way we commonly measure blood sugar control, because sometimes less really is more. Dysphagia or trouble swallowing, this is like 18 lectures in itself, but if you're suspicious, say something and have the individual evaluated. It may not be a progressive issue. It may actually be related to reflux. Also, think about it in somebody who has recurrent pneumonia, who you may not think is aspirating. You may need to look and be sure. So we see self-talk in a lot of people with intellectual disability, and certainly we know it's really common in people with Down syndrome. It's not a bad thing. I mean, think about it. We all talk to ourselves. It's just many folks with intellectual disability don't internalize it like we all do. Like it's a great thing when an Olympic athlete does, but not when a Special Olympic athlete does it. And just why? It may reflect depression, anxiety, OCD, so pay attention to the tone and quality. Autism, so we are recognizing autism more. We don't know if it's the rates are truly growing or if it's just more recognized. There is a decreased life expectancy in someone with autism and an increased risk of premature death. We don't have any data on the risk of dementia in this patient population. This is a patient population where there are higher rates of epilepsy, which can increase the individual's risk for injury and is associated with sudden unexplained death. We know hospitals are rough places for people with autism, or autistics as they sometimes prefer to be called, with identity first language. So we need to work really hard as a care team to try to keep them out of the hospital. Sorry, that was a quick shift from Down syndrome to autism. I almost missed my own cue. What do we know about autism and aging? Again, like we've already talked about, there's lots of comorbid conditions and unmet health needs. If you see a behavior change, don't, blame it on the autism or the dementia, but take a deep dive to see what else could be causing it. We know that people with autism may have really limited diets. And so if you add that to aging, we may see some significant vitamin deficiencies that contribute to cognitive decline. Again, common things are common. And we know people with autism as they age, may have higher needs of unmet physical and mental health needs and maybe missing some of the basics like tetanus shots and cervical cancer screening. So again, we've, I think, kind of made this point in general, for folks with intellectual disabilities, the risk of dementia is about the same for the general population, except for Down syndrome. And there you go. There's the NTG, EDSD all spelled out. So I'd encourage you to take a look, think about how you might use it. It may be something you need to bring to your medical team as a tool. COVID-19, it's the gift that just keeps on giving. This was an article I did with several colleagues from Jefferson. Next slide. And what we found is that folks with intellectual and developmental disabilities were much more likely to develop COVID and to die from it. So as we go through our, care needs for individuals with ID, including those who are experiencing dementia or cognitive decline, I'd really encourage you to keep up with vaccination, keep working on masking. When we talked about things to do to provide cognitive stimulation, if there's a flu outbreak, an RSV outbreak, COVID numbers, climbing, see if you can do something outside. So there's not so many shushes, don't touch that, and all that stress. Again, COVID brought us some good things, and access to telehealth and televised webinars may be one of them. But some people lost their access to day programs, other preferred activities, and they just haven't gotten it back yet. So what can you do at home to stay organized? Is a visual schedule helpful? Have you carved out that time for exercise like we talked about? Can you keep experimenting with healthy food choices? Maintain those social connections, and you as the caregiver, we can't forget your stress. And have to figure out better ways to help you get through your day. Again, the World Health Organization recognizes adults with disabilities as a vulnerable population, but it doesn't mean our folks are fragile, but we have to think a little harder. The NIH finally in 2023 recognized folks with intellectual and developmental disabilities as a health disparity population. So we hope that means more funding will follow, so we can give you better answers on future webinars and so that you have more tools in your toolbox. You can't forget the whole team. Please take a moment and give yourself a hug, pat each other on the back. It takes all of us, so speak up if you see something that changes. Put the patient in the center, listen to what they're telling you verbally or non-verbally. Again, key pearl, know who that decision maker is for the individual you care about. Keep an eye on that med list, know what the meds are for, don't forget to ask questions. We talked about increased rates of dental health problems and early arthritis. Manage pain. Somebody may not be able to ask for it, but if their hip's hurting, it's going to be harder to engage them in meaningful activity that makes a difference. And again, I think the biggest thing is start early. For the professional caregivers on the call, some of what we talked about today may not apply to the person you're taking care of now, but maybe it will be information that you can use at a later time for the next person's life you make a difference with. Thank you. I think that went a little bit over, but hopefully I anticipated some of your questions and provided the answers. And thanks, Adel, for being here.
Dr. Stevens, that was such a wonderful, extremely informative presentation on the process of aging. We are so grateful for your sharing your information and expertise. We do have some limited time available for questions, and at this point, we'll begin to take the participants' questions. Throughout Dr. Stevens' presentation, Kathy Service, who you have met, and Christine Nugent have been monitoring the chat and Q&A, and Kathy is now going to bring to our attention some of the questions.
Okay, well, thank you, everybody, for your questions. And one thing I want to say that if we don't get to all the questions today, we'll be going over them with Dr. Stevens and be sending, they'll be included with the link and stuff like that you get. So there's a number of questions. There's a question here that was interesting about, we know about self-talk typically presents earlier in life. Is it concerning if it begins later as somebody ages?
That's a great question, and maybe I would, pay attention to the quality. I mean, maybe we all get a little bit uninhibited as we get older. But again, pay attention to the quality. But if it's a change, definitely you want to probe for anxiety, depression. I don't discourage self-talk, but I want to know the why.
Okay. A couple things here, and this goes a little bit in terms of, and I think, I know, can depression mimic symptoms of dementia in people with intellectual disabilities?
Absolutely. So in the general population, we really talk about depression as a cause of pseudo dementia. It's always something we think about. Our general workup in a primary care setting, because I'm a family doc at heart, so I take care of lots of people. You don't have to have a disability. But I do have a special place in my heart. We'll look for common causes and exclude them: B12 and folate deficiency, hearing loss, as a big one. And I have a really low threshold to try treatment for depression, anxiety, whether it's talk therapy, art therapy, music therapy, medication therapy. We know at this point there's not a lot of medications that we can use that really help memory loss. But a trial of a medication to treat depression or anxiety can really help. And I think if you see a big improvement, does it exclude dementia or cognitive decline? No. But if it's giving somebody a better quality of life and they can access more of the environment, go for it.
Great. Now, somebody had a question here about GnRH replacement, which I don't know.
I don't have
Okay.
anything on that for you. Sorry.
Okay. All right, that's fine. We can figure that out. And then a few things about skin conditions, because I know skin conditions can be happening more as they get older. Can you talk a little bit about things like that?
Yeah, so we see this a lot in Down syndrome too, because there's probably some immunodeficiency state. So if somebody is having a change in behavior, if they're also refusing some self-care in terms of grooming, like think about ways to make sure we can work on good skin hygiene. Yeast infections can be more common with overweight and obesity, so take a look in those skin folds. Sometimes for my patients with Down syndrome and folliculitis or other conditions in folliculitis, I'll have them shower 3 times a week with like Hibiclens in those pesky parts, their armpits, skin folds, groin. But again, it's something, don't hesitate to bring that to the attention of the medical care team, because it can make a difference. And then certainly we know folks with dementia who become bedbound are at risk for pressure ulcers. So really pay attention to that and bring in a wound care team as soon as you can.
Kathy, those are really great questions that you brought to our attention. Unfortunately, as the webinar is moving along, we've run out of time for questions. But we do welcome receiving additional ones either in the Q&A or email to us at the Family Support email address that we'd be more than happy to address. I just want to take a moment to share with the participants some NTG family resources that are available on the NTG website. This has to do with family caregiver resources and the email, the web address is there. We also have it continued on the next page. And again, this is just a glimpse of some of the resources that are available. The monthly virtual support group was mentioned throughout the webinar today. So again, I just want to highlight that and let families know that the first Thursday of every month, Kathy's the facilitator, and I'm there to assist and share my lived experience with anybody that joins in. And it's at 8 p.m. Eastern time, the first Thursday of the month. And at this time, I will say that it's the conclusion, and I do once again want to thank Dr. Stevens for sharing her insight and expertise. You know, we are so grateful for her taking time out of her busy day today to be with us, and for all of you for taking the busy time out of your day to be with us. We hope to see you at our next webinar, which will be 2 weeks from today on Tuesday, March 12th at 1 p.m. Eastern Time. The topic will be early screening for cognitive changes. Please feel free to contact us at the family support email address displayed on the screen, or put a note into the Q&A box, and we'll be happy to get back to you at that point. And the last screen that I'd like to display contains our survey, because we are interested in your feedback. You certainly are welcome to use the QR code there with your phone, or the SurveyMonkey link. And I'm just going to ask Christine Nugent if you would kindly make sure that that link is in both the chat and the Q&A box in case somebody wants to access the survey through that method. And again, we thank you so much for your time and wish you all a wonderful rest of the day. Panelists, please stay on the webinar. And participants, again, we thank you for your time and do appreciate you completing the survey. It's very quick and very valuable information for us.
Thank you for joining us. We really appreciate it, and we're really glad to have you here.
Okay, and are
Mm.
there any concerns about the survey coming up in the chat or the Q&A? Kathy or Christine, are you coming across any of that?
I don't see any issues. Hold on.
No issues so far?
No
Okay,
issues so
so-
far. Let me
Yeah,
just
so
look.
again, yeah, participants, please feel free to send us your questions if you're unable to access that. Again, your feedback is very valuable to us.
I don't see. People are slowly leaving. We can see if there's any. Oh, yeah. First, it's a good question about how do you get docs to do what they're supposed to do, Mary?